Welcome, everybody, to another CloudGuard Security Done Different podcast. And I am delighted to be joined by Michael Knight, the Chief Information Security Officer for NHS South East London. Michael, welcome to CloudGuard's podcast.
Wonderful. Lovely to be here.
Great. Would you mind sharing with our listeners a little bit about yourself and what you do?
Okie doke. So I started my kind of NHS career back in 2009, kind of started very much in the IT operations world and kind of moved my way up into doing a little bit of business continuity and disaster recovery management and capacity management on the national programme for IT. And kind of following that, I had my first opportunity to step into kind of head of infrastructure role. Did my CISSP, immediately got caught up into WannaCry, which was particularly interesting. And then kind of from there, I've done various kind of tech roles, associate director, CTO, as well as a bit of a stint as program director. So I've been Chief Information Security Officer in South East London since last July. And it's certainly been an interesting start.
Certainly sounds it. And certainly if WannaCry was the beginning of that journey as well from an external point of view. So, okay, from our point of view, today we really want to focus on the cyber assessment framework, and obviously from a healthcare, from a social healthcare, from a supply chain to healthcare provision point of view. CAF is obviously, very current. Obviously, there's existing frameworks with obviously the Data Security and Protection Toolkit, the SPT. How do we see that in the sort of progress, if you like, of preparing NHS organisations who are unfortunately still very, very heavily targeted, and the impact that we all know can be so significant? How do we help in terms of real-time security monitoring and particularly response and recovery planning in terms of objectives C and D, if we can refer to them as that?
Mm-hmm. So I think definitely kind of Data Security and Protection Toolkit that is now aligning to CAF. It's got a long history, it's well established, but a real focus on the kind of the privacy and information governance, and there really is that need to shift to better align with cyber. So this year we're seeing that change kind of happening for real. Initially for NHS trusts, integrated care boards, and some of the larger kind of arm's length bodies. So we'll see further evolution of that across the broader health and care sector in the coming years. But I'm really pleased to see that. We've had fantastic leadership nationally over the last 3 to 4 years around cyber, and I was really frustrated with previous regimes because we weren't clear about what the expectations and requirements were. Is it DSPT? Is it Cyber Essentials? Is it Cyber Essentials Plus? Do we do ISO 27001? So it's fantastic to see those things coming together now and having a really clear expectation. It certainly helps me in terms of engaging with senior leaders about what needs to be done. There's no ambiguity about where we need to be and what needs to happen, which is fantastic. And seeing that alignment with CAF is super helpful. Gives us one point of focus. In terms of those objectives, C and D, and I think it's fair to say, depending what type of NHS organisation you're in, to be fair, there's a significant level of complexity, which can be really challenging in terms of kind of your objective C. And I definitely would say that kind of your objective D, we've got really well established emergency planning capabilities, of which kind of cybersecurity needs to plug into. But I personally still feel that many health and care organisations kind of, the objective D is somewhat of a kind of Cinderella objective for many organisations. And we really do need to be making sure that when we think about cyber risk, there's loads of things that we are doing actively in that world of, well, how do we reduce the likelihood? But we really need to think about the other half of risk in terms of, well, what about the impact? And that's where objective D comes in, and it's really important.
Certainly in the conversations I've had with yourself and with others, they've pointed very positively to, okay, PSN took us up to here in terms of the audits and the checks for healthcare. But actually what CAF is really doing is positively challenging us to think about not just impact, but recovery testing and the performance metrics around recovery testing. What do you think are the critical components for healthcare in relation? Let's just focus on that recovery and response planning.
It's really interesting in terms of that kind of the that evolution, that framework. It would be great to have had it well before now. Best time to plant a tree was 20 years ago, and the second best time is now. This is a really significant change, and I really welcome it. And we reap what we sow. And so we really need to make sure that we put the time and effort into that, making sure we handle that impact side of the risk equation. But of course, it's tricky, right? So we want to do as robust rehearsal as possible. But it's a really complex system, and it's really difficult to say, right, okay, well, we're going to stop people coming in for an emergency department for a couple of hours, or we're going to stop doing outpatients services for a couple of hours. The NHS doesn't stop; it's a 24/7 organisation. So we really have to be kind of clever around how do we do that, how do we do that testing, make sure that we get genuine value out of it, because it is really important. So there's loads of really helpful stuff provided nationally that we can lean on, as well as things through NCSC and through even kind of local police and law enforcement that can help with those kind of rehearsal exercises, which is fantastic. It's super helpful. But yeah, we need to be willing to stand up and kind of make the case to be doing that rehearsal stuff, because it's an absolutely essential component of how we tackle that impact half of the cyber risk equation.
Because I think obviously from a high profile disruption and emergency status point of view, so much of the challenge is actually falling into supply chain scope as well, isn't it? In terms of how do you simulate those tests beyond the boundaries of your direct influence and control, and actually look at, okay, so with such a complicated supply chain, where do you begin? How do you prioritize? Because the disruption and the threat vectors could come from any and all.
Absolutely, it's a really significant challenge. You think about the NHS and broader social care as well. That has it's one of the largest organisations, if you treat it as one. It's one of the largest organisations in the world now, and it's complex in terms of what it delivers. Right, so there's the supply chain that sits underneath that is no different. So certainly, lots of the early work that I've been very focused on, kind of coming new into post, is really drawing that line between what services do we provide, what is essential, what's our risk treatment around those services. So if we have an issue, what are we going to do? So there will be some things that we might say, okay, well, those can stand down for a period of time, and that's fine, and that's totally okay for us to have that sort of risk response and make sure we can prioritize the right things if we do have a really significant incident. And then that then drives through into, okay, what are the essential functions that we're maintaining, and what's the supply chain that underpins those things. So certainly for me, on supply chain, trying to get started on some quite kind of quick and fast analysis of those suppliers that I can identify early, but over time I want that to evolve and be much more integrated with our essential services and functions, and how do they underpin those key outcomes, and how does it link in with the risk treatment? Because we can't boil the ocean. We need to understand who's really important and why, in the context of how we're gonna treat that risk, because we may have organisations, you can be very binary about it and say, okay, well, we'll just look at the organisations we spend lots of money with. They may not be that critical, and likewise on the flip side, there'll be organisations as part of the supply chain that there's very little financial transaction involved, but they are absolutely critical to maintaining that service. They underpin a key function, and I think certainly when people go through incident response, it's always the things that you don't expect that catch you out, and then you go, oh, okay, well, how are we going to get around that challenge? It's a really small supplier that we didn't even think of. So yeah, certainly challenging.
Obviously, cyber resilience, improving the speed of response, speed of recovery, particularly, is priority, not just for NHS, but all organisations. But do you think now is the right time for, CAF to actually challenge that and increase its, priority in the organisation for NHS trusts?
It is a significant change. It takes time to get it right, and I really welcome it. And it's really important that we work at pace. I think definitely we have seen, certainly over the last couple of years in particular, but even if you go all the way back to the days of WannaCry, there are two really key parts of the risk management kind of calculation, really, isn't there? There's a likelihood and there's the impact, and we spend loads of time looking at the likelihood, but we also need to make sure that we're looking at the impact bit, and that really I say that takes a village to make sure that we get right. And really, I'm kind of leaning on this move to the new version of the data security and protection toolkit to really get that commitment, buy-in, and kind of contribution from the rest of the organisation. It's really not just for me as a chief information security officer to address. It's the whole organisation that needs to know what is it that I need to do to make sure that if the worst happens, how are we going to keep the show on the road?
And do you feel that, and thank you for that, do you feel that there is a sort of complementary approach, between the latest version of the toolkit and CAF? Or do you feel that there is some crossover and we need to be smarter about how we help organizations actually approach it in terms of here's improving resilience key points, here's lessons learned from others, here's the elements of recovery we really want to focus on because we know these have the greatest impact to trusts in terms of patient care, patient service, when disruption does occur?
Certainly, one of the areas that I've been really focused on is about having a very clear view and thinking about network and information systems regulations, being really clear about your essential services and your essential functions. Now, when we look at NIS, it talks about health as a very broad thing, but actually, not every part of the health and care system is necessarily as critical as the rest. So, we're working within constraints. We have to be really clear about what will hurt us the most, and really focusing on that. And in terms of that, you touched on the point around moving kind of to the CAF aligned framework. Certainly, there's been lots of national work done by colleagues in NHS England to map that for people in advance. So I know many colleagues have taken up that guidance and used it, but I think certainly we are doing the hard yards locally to really get into the detail, really make sure we understand, really make sure that what we are doing and we have been doing now is fit for this new framework, because now there will be lots of complementary things, but it's not necessarily exactly the same. So yeah, lots of hard work for people over the last 12 months, it's fair to say.
So, I mean, one of the things we've seen elsewhere is that, because it is such a large and complex supply chain in NHS, if you just break down response and recovery in terms of organizational resiliency, objective D and CAF, one of the big things that we're still not fully, I guess, getting our arms around is the ability of helping the team and avoiding burnout, actually where these issues, come from. And they could emanate from anywhere in a supply chain, but the impact is across, the NHS trust or the NHS healthcare provider entity at that point to recover it. And that recovery can be 6 months. And that is a huge amount of time and resource that you suddenly have to reprioritize from, year-long plans for your resources. What learnings would you call upon to say, actually, we can do better, or we should learn from, the recent issues that we've had? And this is actually how we should, incorporate this into, a subset of CAF?
I think there's definitely a key piece there in terms of the having a really, coming back to the essential services element, being really clear around essential services, but also beyond that, the kind of trying to get a really full picture and not saying, okay, well, that's not essential, so we don't need to worry about it. Being really deliberate about what your risk treatment is, and also being quite deliberate around, okay, well, if one thing kind of drops in one part of the system, really thinking about what decisions might we be able to make to mitigate that impact when we're in that incident response situation. So, actually understanding the areas where we may have particular skills that can help us clinically and operationally to work through an incident and to kind of plug some of those gaps. And that's really, really key. We can tend to really set back some of our very long-term objectives, if you said, in terms of things like outpatient appointments, that tends to be a place where there are compromises made early in incident response. So having a really clear focus on, right, okay, well, how do we get back to that? Because we know NHS kind of has got a challenge in terms of backlog of elective procedures and that kind of thing. So I'm really, in my role, trying to make sure we understand the whole, trying to understand that full risk treatment and understand what we might be able to kind of pull on. But it's certainly a task that I am leaning really heavily on my colleagues to support me with, because they really know and understand exactly how these services operate on a day-to-day basis.
And obviously, in smaller, far less complicated, organisations that we see CAF operating in, it is possible to look at that risk treatment and look at simulation, getting really quite close to different risk scenarios and different impact testing profiles, etc. That's not possible as far as we all can see in NHS. Is there anything that we can do as security service providers to help? Do you think in the NHS to get closer to more simulation? Because part of the challenge is we have to move an affected entity into an emergency situation straight away, and already you've got high levels of impact across the board in all of the key metrics that you operate to.
So I think it's clearly 24/7, 365 days a year service, the NHS, isn't it? So as you say, taking that time to be able to say, okay, we are going to go really, really close to what would be a full kind of operational failover or kind of rebuild, whatever your kind of incident response and recovery would look like. That is a real challenge, and a really hard sell. I can remember a number of years ago having to go in some really challenging conversations just about taking kind of half an hour window to be doing reboots after we've patched, and doing that once a month. So that's really the kind of the nature of it. So I think certainly the key challenge, I think, for the NHS is actually what we've seen from many incidents. It's also as much about the data catch up. So we capture lots of data that's really important about patients as we're treating them. The data catch up is a real challenge as well. So understanding that's also quite key. So yeah, a real challenge in terms of how can we push the envelope in terms of what we really get from kind of the tabletop type exercises, but also thinking about things in the context of, well, where might we be able to temporarily build a copy of certain platforms, and without that kind of operational impact, be able to kind of technically rehearse. I think the operational rehearsals, there's lots of stuff that we can lean on that is provided within health and care, as well as kind of supported by local police forces, etc. So there's lots of things that we can kind of look to, but certainly in health and care, as you say, it's a real challenge to get that really, really close, close to real life response. But what we do have in the NHS that helps us is very mature emergency planning processes and professionals who are used to dealing with a really broad range of scenarios. So actually lots of the work that needs to happen outside of digital, people are actually quite well rehearsed at responding to incidents. Probably more so than you'd actually like to have the practice at. Sometimes it's certainly a challenge to make sure we keep all of those rehearsals going and really commit to them.
And we see it time and time again, don't we? The high levels of responsiveness and operational care that are provided when there are major incidents, up and down the countries. Is there a significant operational overhead to try to synchronize that if you go into, an emergency situation, for those of us that are trying to understand how we help, more effectively, in incident response?
Certainly. I mean, I think what one kind of example that I could kind of give would be to say, okay, well, if you think about say if East London, for example, then let's say you've got 7 or 8 different health and care kind of partners involved. You might have 3 hospitals, 2 mental health providers, number of community providers, the integrated care board, all involved, as well as working with NHS England regionally and nationally. and then also having multidisciplinary teams involved in that response, where you've got many teams across many organizations all really trying to work together. Let's say you've got one representative per team per organization, you very quickly build quite a cast of people that are involved in response. So certainly the emergency planning protocols that we have are super helpful. I think there's work we can do as cyber professionals to make sure that we really know and understand and can properly integrate with that. Because as I say, those protocols are designed for a large number of different scenarios, and actually meant, the cyber response scenario has some very specific aspects to it for particular teams, but much of it is actually quite consistent in terms of other things that we might respond to, given just how critical and the kind of events that health and care might have to respond to. We're talking response to potential really significant incidents where we are taking large numbers of injured people into hospitals, for example. So we have really good protocols for those things, and they do apply quite nicely to cybersecurity incidents.
So one of the areas, we're all, I guess, super excited about exploring is obviously we've started the adoption of AI and automation-led simulation tools, in lots of surgery and now in other parts of healthcare and diagnostics as well. Is there a feeling that we can embrace that, in terms of simulation of improved incident management, particularly where you've got such a complex network of interdependencies from what you've just described?
Sounds like exactly the kind of thing that we could really do with looking at and trying to gain that benefit from. I think certainly, in my experience, as you are doing that rehearsal, what you tend to depend on is someone that's really experienced and with that nous to just ask that right question in terms of, but how are we going to do that? Because picking out those assumptions about how things will actually work in reality, that's what really makes your incident response. So I remember in a previous life responding to an incident and talking about, right, okay, well, how are we going to manage the recovery over 3 different campuses, many different departments, different areas of the buildings? How are we going to systematically do that? And actually, it came down to me kind of pulling in somebody who'd worked at the hospital for 15 years and kind of, probably knew every nook, cranny, and cupboard in the whole trust, and that was helpful to me at the time. But actually, in incident response, when you're doing that rehearsal, you need someone to go, okay, you're going to work your way through a ransomware response to the hospital. What parts of the hospital are you going to go to? Where do you have devices? How are you going to find that information? And that's it's that kind of thing that's really important. So having tools to help us with that, I think could be fantastic.
But we see this time and time again, in organizations where you will see really different levels of recovery performance in organizations where you've got a key individual that really understands that business, its supply chain, and the interworkings between, disparate teams, etc. And particularly if you're going across multi-campus scenarios, as you just described. And let's say that person, is on holiday, for example, and the recovery of the business in that scenario. So no different from what we've seen in other organizations. But is there a way in which we can, I guess, start to use the technologies that we are starting to use to automate lots of cyber triage, lots of investigation techniques, and enrich that with those questions that are saying, right, so, okay, pause. What are we going to do in terms of this scenario and this interface, given all the inputs that we've fed into the model?
I mean, I think if you take it back even to a more basic principle in terms of thinking about kind of your kind of general IT controls, your IT service management controls. Now, what's the area where we tend to see some challenges or less consistency across many organizations? It's, well, particularly when we're delivering at pace, the documentation is always the challenge and the thing that when you're getting ready to go live. Certainly when I was doing IT service transition many years ago, the thing I would always be looking at is,
okay, well, have we got the documentation in terms of the technology, like how the technology fits together, disaster recovery plans, all of those things. And so actually, if we can apply some of those tools as we are doing the exercises and getting value from it, but actually helping us to create the right records that we then need, that we can then refer back to when we are in a scenario where potentially we're lacking a particular individual who's got a whole chunk of that knowledge. That's the kind of thing that we should be trying to use automation for, because ultimately it takes work away and allows us to prioritize on the real high value stuff, which is making sure we are being as proactive, as preventative across many other disciplines. So if we're doing the exercise anyway, let's get as much value from it as we can.
So great opportunity there, I guess, to tease out the main highlights of this, from a CAF point of view. Obviously, the introduction and the focus on real-time monitoring, giving us the ability to see things, earlier than we potentially are seeing them in certain areas right now. And obviously the focus on Objective D, recovery and organizational resilience aspects of this. What would be the elements you would highlight to the audience here in terms of the benefits of CAF and the learnings of those, early stages of CAF implementation from your perspective?
I think the key things that I've kind of used it for is, I think this is a real opportunity to kind of reinvigorate kind of teams and really start to change the kind of conversations that we're having, just off the back of having something that is new. So I think it's a great lever in terms of your change management. So if you're a Cotter guy like I am, you'd go straight to, okay, well, we need to build some urgency and we need to build a guiding coalition to help drive through that change. So certainly movement to a new framework with broadly similar, but a number of new requirements for us as organizations. That's fantastic. That drives out the need to change, and that has been certainly helpful for me in terms of engaging senior leadership, but also engaging teams. So that's a real key area. I think it also gives us an opportunity to really make sure that we are getting the governance right, and we are looking at how we bring together our privacy professionals and our cybersecurity professionals. Because I think what has happened in the past in some organizations that I've seen, there's kind of been that divide between the data security protection toolkit being an information governance and privacy thing, and the cyber folks kind of doing the privacy professionals a favor and giving them some evidence. I think this really is a change towards much more multidisciplinary work, in really looking at how can we bring those two professions together, because there's lots of work that we already do, and a really fantastic job of through our privacy professionals. We do data protection impact assessments. They normally cover a whole chunk of cybersecurity questions in there. So really integrating that ways of working is really key for me. Real opportunity to kind of reinvigorate the governance bit, and I think a real opportunity to come back to what I kind of call the Cinderella section of Objective D, in terms of really having that incident kind of preparedness nailed.
I absolutely agree with you, Michael. I think that the key here is, let's focus in on those key points of collaboration improvement, between the teams that you've spoken about, starting early and embracing it as an opportunity to improve further, obviously to improve the performance and to get those metrics really clear and focused as to how you're going to measure that improvement as you go through CAF, and obviously DSPT toolkit's latest implementation. And obviously focus on the priorities. It could be different in your organization based on past performance or lessons learned from colleagues in other healthcare sectors as well. But opportunity rather than burden, message loud and clear, Michael, and I completely support that. Thank you so much for tuning in. My special thanks to Michael Knight for his great insights and contribution and a lively conversation. Tune in to the future episodes of Security Done Different, where we'll be taking on some really interesting topics. And hopefully, Michael, you can join us in the future for some of those. So thanks again. Thank you for listening.